All right, let's get straight to it. For your FRCS exam, you absolutely must know Rothwell's 2003 reanalysis of the European Carotid Surgery Trial. Now, this isn't just another paper. This is the study that solved a huge controversy that had been raging in vascular surgery for decades. It literally defined the way we practice today. So let's break it down.
So, for years, surgeons were in a real bind. You had these two massive landmark trials, Europe's ECST and North America's NASCET, and they were giving conflicting advice. ECST was saying, look, surgery really only helps if the stenosis is above 80%, but NASCET set the bar way lower, at 50%. This wasn't a small disagreement. It led to years of confusion and completely different standards of care depending on where in the world you were.
So here's our game plan. First, we'll dive into that initial controversy. Then, we'll see how the methods were finally harmonized. After that, we'll get into the reanalyzed results, the real meat of the paper, and see how that changed modern practice. And we'll wrap it all up with a dedicated exam blueprint to make sure you have the key facts locked in for your Viva.
Okay, let's really frame the problem here. This conflict between ECST and NASCET, it wasn't just some academic squabble. This had massive implications for real patients, deciding who got offered a carotid endarterectomy. And as you know, that's an operation with huge potential benefits, but also some very real risks. So figuring this out was absolutely critical.
This is the big question, right? And it's exactly the kind of thing your examiner might throw at you. How is it possible that two huge, well-run, randomized controlled trials looking at the exact same clinical problem came up with such different answers? Well, the secret wasn't in the patients they studied, but in how they studied them. It was all in the methodology. And it really boils down to two key differences. First, how they measured the stenosis. You see, ECST compared the narrowest point to the widest part of the carotid bulb. NASCET, on the other hand, compared it to the healthy and much narrower distal artery. Now, because NASCET used a smaller denominator, its method always gives you a lower percentage for the exact same plaque. Second, their definitions of a stroke were different. ECST only counted symptoms that lasted more than 7 days. NASCET used a much more sensitive threshold of 24 hours, and they also included retinal infarcts, apples and oranges.
And this is where Rothwell's team comes in. Their idea was just brilliant, simple in concept, but an absolute beast to execute. They didn't need to run a whole new trial. Instead, they went back to the original ECST data and basically redid the analysis, but this time, they played by NASCET's rules.
And they were incredibly meticulous about it. First, they went back and remeasured all 3,018 of the original ECST angiograms, but using the NASCET method. That created a level playing field. Second, they went through every single patient outcome and redefined it to match NASCET's more sensitive criteria. Finally, with this new, perfectly harmonized dataset, they crunched the numbers again using ECST's amazing 73-month mean follow-up.
Now, during this whole remeasurement process, they uncovered something absolutely critical, a subgroup of patients they called near occlusions. And listen, this is not just a really tight stenosis. This is a lesion so bad that it's choking off the blood flow, causing the artery to actually start collapsing on itself distally. And it turns out identifying this specific group was the key to solving the entire puzzle.
So, how do you spot a near occlusion? Well, on an angiogram, you're looking for a few telltale signs. Obviously, a very severe stenosis, but also delayed filling of the contrast eye distally, evidence that collateral vessels are trying to compensate, and that visible narrowing or collapse of the ICA after the plaque. They even quantified it with a ratio of the internal to common carotid artery diameter, less than 0.40 in men and 0.45 in women. Make sure you remember these criteria.
Okay. Now for the results. This is really the moment of truth, where all that work harmonizing the data finally brought incredible clarity and put an end to decades of debate.
But first, let's talk about risk. We have to remember the context of the time. The 30-day risk of a stroke or death in the ECST surgical group was 7.5%. Just let that sink in. That is high by today's standards, where we're aiming for less than 3%. Any benefit from the surgery had to be powerful enough to overcome that significant upfront danger.
And here it is, the core data. The results are just crystal clear. Below 50% stenosis, surgery was either harmful or did nothing. In the 50 to 69% group, the benefit was pretty borderline, with a number needed to treat of about 18. But in the 70 to 99% group, and this is crucial, without near occlusion, the benefit was staggering, a 21.2% absolute risk reduction, with a p-value that's off the charts. Now look at that last row, the near occlusion group. Here, surgery was actually harmful, with a trend towards doing more bad than good.
This brings us to the single most important number from this entire paper. If you remember one thing, remember this. For symptomatic patients with 70 to 99% stenosis, the number needed to treat to prevent a stroke is 5, an NNT of 5. That makes this one of the most effective preventative operations in all of medicine. You have to know this number cold.
So the conclusion is just stark and simple. For severe 70 to 99% stenosis, surgery gives you a huge, lasting benefit. But for near occlusions, there is zero benefit and maybe even harm. The data showed that even though both groups have very tight blockages, their outcomes after surgery are fundamentally worlds apart.
So how did these incredibly powerful results change what we do every day? Well, this single reanalysis basically rewrote the clinical guidelines and created the modern consensus on who should, and just as importantly, who should not, get a carotid endarterectomy.
And here are those guidelines, essentially boiled down for you. Surgery is strongly recommended for symptomatic patients with 70 to 99% stenosis, as long as it's not a near occlusion. You can consider it for the 50 to 69% group, but only if your local surgical risk is very low. We're talking less than 3%. And crucially, we avoid surgery in patients with less than 50% stenosis and in those with near occlusions. They get medical management. And by the way, the NASCET measurement method is now the universal standard.
Now, a good examiner might ask you to critique this study. Its strengths are massive. That long 73-month follow-up is incredible, the crossover rate of less than 1% is almost unheard of, and the whole blinded remeasurement of the angiograms is a very robust method. But you have to acknowledge its limitations, which are mostly about the era it came from. Best medical therapy back then didn't include statins or dual antiplatelets. That 7.5% perioperative risk is way higher than our modern standards. And at the end of the day, while it's a reanalysis of a great trial, it is still a retrospective analysis. Okay, let's shift gears into our final section, the exam blueprint. This is the rapid-fire review. These are the absolute high-yield facts you need to have right at your fingertips when you walk into your Viva.
First question. The examiner leans forward and asks, so tell me, why did those two big carotid trials, ECST and NASCET, originally report such different thresholds for benefit? What's your answer?
Your answer has two parts, nice and clean. First, the method of measuring stenosis was different. NASCET's method used a smaller denominator, which always gives you a lower percentage. Second, the way they defined a stroke was different, with NASCET using a much more sensitive definition. Those two methodological points are the entire reason for the original discrepancy.
Next up, a pure numbers question. What is the number needed to treat for a patient with asymptomatic 70 to 99% stenosis, assuming no near occlusion?
The answer is 5. An NNT of 5. You need to operate on just 5 of these patients to prevent one major stroke or death at 5 years. It is the most powerful and memorable statistic in this entire paper.
And it really helps to have a mental timeline of this whole story. So, 1991, the first positive results for severe stenosis come out. Then in 1998, the final but conflicting results are published, which creates all the confusion. And then finally, in 2003, Rothwell's landmark reanalysis drops, resolves the whole thing, and sets the guidelines we still use to this day.
So in the end, this incredible paper proved that the two original trials were actually consistent all along. They just needed to be looked at through the same lens. It gives us the core evidence for why we operate, who we operate on, and just as critically, who we don't, especially those patients with a near occluded artery. Your examiner will absolutely expect you to know these thresholds cold.